All right, so patient history for pelvis femur. What, where, when, what's wrong, where is it wrong, when did it become wrong? So why are you getting this x-ray today? Follow up on your questions. Are you having any pain? If so, where, how long, does the pain radiate? Use the scale 1 to 10, definitely when asking about pain. Note any swelling or bruising, dislocation if injured. How did it happen and when did it happen? So any history of previous surgeries, if no surgery, ask questions related to disease, arthritis, osteoporosis, cancer, and then always LMP for females ages 10 to 55, and that may vary depending on your clinical site. They may have a different end date of say 60 or 50 or something like that. So definitely make sure you know, and it's never wrong to ask. So patient preparation, may move the patient to a table or do in the bed if it is a trauma. Remove any artifacts, so always have them take shoes, pants, change into a gown. Make sure belts, buckles, keys, phones, snaps, zippers, anything within the pelvic region is removed. Gonadal shielding, if possible, is possible if very careful. Usually not used due to risk of covering the essential anatomy. Thyroid and breast shielding can be utilized on patients, but most of the time we don't shield gonads. So I know that I've mentioned to some of you that sometimes techs will just tell them to pull their pants down to their knees. To me, it's always better just to go ahead and remove the pants, change them into a gown. They can leave their underwear on and sometimes their shoes, but I always try to remove the pants, leave the underwear on, give them a gown, cover them up to image the pelvis and femur. Preparation. Female patients always verify LMP, pregnancy status. Also remove belts, buttons, snaps, zippers, anything that's going to cause an artifact and possibly cause you to have to re-expose. Place the patient in a gown, sometimes scrubs if they have them, depending on what their protocol is at the hospital, but it's usually just a gown. Question a patient for presence of contrast, so maybe they had a BE, an upper GI, a CT. So barium can obstruct that anatomy, especially with the bladder and surrounding the area of the bladder. So always ask if it's how long it's been, if they've had a BE, if they've had an upper GI, any kind of contrast, so it's had time to move out of the area and won't cause a repeat exposure on your patient. Question your patients regarding orthopedic prosthesis. So if they've had a prior hip surgery, is there a prosthetic? Do they know how far does it go? Does it go all the way to the knee? Is it just a short one? And that may affect imaging of that anatomy and what you may have to do. So if they don't remember, it's no big deal. You'll see it when you take that first image, but try to remember to ask. So as you can see here, they're showing what can happen. So this is contrast left over, obscuring the wing of the ilium or the ala of the ilium. So you want to make sure that that's allowed to move out. This one here didn't verify pregnancy status. There is an infant in there. You can see the head, the backbone, the ribs. Navel piercings. So always make sure that you ask about those. Those belly button piercings will show up in that anatomy that's necessary. So always ask and then see if they can't remove them. You're going to be at a 40-inch SID. It's on the table, usually on the table. So 40-inch SID. It's in the grid in the tray bucky. So there's going to be a grid. Long axis of the body part with the long axis of the image receptor, with exception of the pelvis. So the pelvis is crosswise. Okay, so crosswise for the pelvis, and then everything else. The femur is lengthwise, and then your frog legs are as well. So your frog legs are an 8x10, but it's laid in there crosswise because your frog leg comes across crosswise. onto that image receptor. So collimate to the length of the IR and to the skin edges crosswise. Correct part and central ray alignment. So know your central rays. Know the part that you're imaging. Make sure the part is parallel to the image receptor and the central ray is perpendicular to the part and centered to the image receptor. And then always the proper side marker, the anatomic marker, on a lateral side, on anterior side, on lateral projection. So when you're doing a lateral, make sure it's on the anterior side of that lateral. And then just mark the correct side. That's most important. So male gonadal shielding, you can see this small shield right here covering the gonads. This is what the book shows, but you will more than likely never see this in clinic. They just don't use them because they're so hard to place, because you have the possibility of clipping these inferior ramus on that pelvis, and then you're just going to have to image again. So you can use a small contact shield. The top border at the inferior margin of pubic symphysis, so inferior margin of pubic symphysis, but keep in mind you may not see these, but you can shield for a pelvis. Abdominal and pelvic shielding for a female. So when you're doing a femur, proximal femur, you can shield the gonads for a female patient because of the position of the gonads. So make sure that when you're doing a proximal femur that you talk to your clinic site, your clinical instructors, to see if they use gonadal shielding. That way you know if you need to use it or not. So this is what the gonadal shielding looks like for a female patient. And you can see that you do have that possibility of clipping that the brim of that pelvis. So a lot of times it just depends. Most of your protocol, if you're doing an entire pelvis, the clinic sites and the protocol that they have aren't going to require shielding. Know that you can shield, but most of the time that you won't shield. So this is the ovarian shield for the hips and the proximal femur. So this is just for the frog legs that they're imaging. It's not for the entire pelvis. So you may be able to place a shield for the proximal femur, for the proximal frog leg femur, if that's all that they're looking at. So just know your protocol, where you're at the hospital, and if that's something that you're going to do. So this is showing kV and dose comparison for a pelvis without gonadal shielding. So 80 kV, 90 kV, 12 mass, 8 mass, male 98, female 36. So there is a difference in shielding and not shielding. So always keep that in mind. Femur. So most average adult femurs require 2 AP and 2 lateral projections, proximal and distal, due to its length. It's not going to fit on a 14 by 17. Standard methods use 14 by 17 lengthwise image receptor with overlap in the mid femur. So if the leg is shorter, you may use a 10 by 12 or 11 by 14 lengthwise for joint areas, because you have to include both joints, the hip and the knee joint. So depending on the size of the patient, you may do 2 14 by 17s overlapping mid-femur, or 2 10 by 12s overlapping mid-femur, or 2 11 by 14s overlapping mid-femur, just depending on the size of the patient. Make sure all the femur is included and don't miss a section if using a smaller second image receptor. Always make sure that you have good overlap of that femur and you're not missing a section of the femur. So AP mid and distal femur, so mid and distal, 14 by 17. Still, you're going to rotate that leg about 5 degrees internal, okay? So that puts it in a true AP position. So bottom of your image receptor is about 2 inches below the knee joint. So the knee joint is a ½ inch below the apex of the patella, so that image receptor should be about 2 inches below that knee joint. So 2½ inches below the patella, or a good 2 inches below that patella. So your central ray is perpendicular to the midpoint of the IR. They're in the middle of the IR. So that's putting it kind of mid-femur, a little bit low on that mid-femur. And that's why it's going to be 2 images, because you're not getting your hip joint proximal. So here you can see your distal femur. So it's including the knee joint, no rotation. Make sure that you do rotate in 5 degrees on that leg. So you're going to rotate this leg in 5 degrees. So you are in a true AP position. Your patella is in a true AP position in the center of your femur. Optimal exposure factors, but you're going to include the distal femur and that knee joint. Okay? So AP proximal femur. Proximal femur, you're going to have overlap. So right there is about the amount of overlap that you're going to have, which is really good overlap to have. You're going to rotate your leg internally. So this is for your proximal femur. You need to rotate it internally 15 to 20 degrees. Okay? So that's bringing those toes up and in 15 to 20 degrees, because you want to hide this lesser trochanter and you want to visualize your greater trochanter. Okay? So top of the 14/17, so it's lengthwise. The image receptor is at the level of the ASIS. So top of your image receptor is at the ASIS. Okay? Central ray is perpendicular to the midpoint of the image receptor, and then the center of the femur to the midline of that image receptor transversely. Okay? So side to side, it's going to be in the center, and then top to bottom, the top of the cassette at the ASIS, and then the midline of that image receptor is coming right down the midline of that femur. Okay? So lateral, mid, and distal femur. So lateral, mid, and distal femur. True lateral, you're going to flex the knee 45 degrees. So this is a different flexion on the knee as compared to the flexion for the knee. So when you're doing a true lateral for the femur, 45 degrees on the knee, midline of the femur to the midline of the image receptor, bottom of the image receptor 2 inches below the knee joint. So you want to make sure that you're going to include that entire knee joint flexed 45 degrees, central ray perpendicular to the midpoint of the image receptor. Use your shield on the proximal portion of the patient, and then you'll move that shield when you image that proximal femur. So here is a trauma. It's a lateromedial, so you're coming in lateral to medial. There's no flexion on the knee because you're not going to want to mess with that. So you're just going to set up lateral to medial. Make sure it's in a lateral position as possible. You may need to rotate the leg in just a little bit if you can, but just get it as lateral as possible. So you can always place the support under the affected leg and knee, support the ankle. Sometimes techs work in teams, so one tech will hold the lower leg while the other tech positions and makes the exposure on the distal femur. So place the image receptor on its edge against the medial aspect of the thigh to include the knee. So you need to include the knee, so make sure that you're a good 2 inches below that knee joint. And then with a horizontal x-ray beam directed at that lateral side, you'll make that exposure. So the criteria, lateral, mid, and distal femur, you need your knee joint included, which is minimum. Minimum of knee joint included. No rotation, optimal exposure factors. You will not get these condyles to lay over top of one another. They won't be superimposed, but that's okay because we're not imaging a knee, we're imaging a femur. You just want to make sure that you get the knee joint so you can see a little bit of that proximal tibia, proximal fibia superimposed. on that image. So lateral proximal femur, it's a frog leg, but you're going to rotate your patient up just a little bit so you can support your opposite hip if it's necessary to help them maintain their position. So their leg is just going to be laid lateral, support the far femur like I said. True lateral, other leg out of the way, so up and out of the way, or it can be relaxed down and out of the way just as long as it's not laying into that femur of interest. Top of the image receptor is at the level of the ASIS. So just like before, ASIS is the top of that film, top of that light field, and then central ray perpendicular to the midpoint of that image receptor and midpoint of the femur. So criteria for your lateral, mid, and proximal femur. Proximal femur is not superimposed by the other leg, so your other leg is out of the way. It's in a true lateral position and then optimal exposure factor. So you'll be able to see the mid shaft, a little bit of the ischial tuberosity. Most protocol calls for the image to include that pubic symphysis. So you want to see that pubic symphysis and a little bit of that other ischium coming off there. So always keep that in mind as well, that when you do frog legs or you do proximal right femur, left femur, include the pubic symphysis on those images, okay? So true lateral optimal exposure factors include your pubic symphysis. So positioning decisions, this is baseline for an AP pelvis. So non-trauma is going to include the rotational hip and proximal femur. Your trauma is going to include a trauma pelvis projection, which you make that exposure with without rotation of the femurs, especially the femur of interest, suspected fracture, non-rotational hip and proximal femur projections. So you're not going to rotate them. You may need to do a cross-table hip for the proximal femur just in case there is trauma. You're not going to want to roll them to their side and place them on that affected hip. So pelvis, basic projection for a pelvis exam order is an AP only. So when you're doing a pelvis, it's AP only, unless they add extra views, and then those are going to be special projections. But a pelvis is one image, AP only, pelvis. Roll your legs in 15 to 20 degrees, and that's what you're going to want to see on your pelvis, because you're going to get some of those proximal femurs, so you want the femurs turned in so you see the greater trochanters, you're hiding the lesser trochanters. Additional special views are usually requested or maybe protocol at certain facilities, which is true. Some facilities, when there's a pelvis, they have extra images attached to it because it's their protocol. Normally, a pelvis exam is just an AP pelvis. So bilateral frog legs is frequent with a follow-up exam on pediatrics. Pediatric frog legs are usually imaged both frog legs on, so both femurs frog-legged on one image. Not until you move to adolescents, teens, and adults are you going to do individual frog legs. So your clinic sites usually have a cutoff point of the age when they're going to do bilateral frog legs on one image. So make sure that you know that. Make sure that you are aware of your protocols. So I'm going to end this one here, and we're going to pick up with some more. So see you shortly.